Welcome back to part 2 of 5 of the Go-To Educator, a mental health literacy approach. We're going to continue on to talk a little bit more about mental disorders. Most youth with mental disorders will go on to be successful at school and live productive and positive lives when receiving proper treatments for their mental illness. Some youth have severe, persistent mental disorders which respond poorly to current treatments, as in all other illnesses, and may require greater supports. Mental illness does not respect any boundaries of race, class, or geography. Poverty does not cause mental illness, but it can have a negative impact on outcomes. Young people with mental illness are more likely to be victims, not perpetrators of violence. There is an exception to this, is if untreated, psychotic episodes are rare but sensationalized in the news. Youth with mental illnesses have difficulty accessing best possible health care and face substantial stigma in social and in school settings. Early identification and provision of best evidence treatments and social educational support can substantially improve outcomes. It is only recently that researchers have been able to look inside the brain with imaging technology, or MRI, or PET scans, or the CAT scan. These technologies have been able to link brain development and mental disorders. Let's review various brain disorders just so you have accurate information to begin to recognize when something may be wrong, and after a diagnosis, feel better prepared to support a student who has this ailment. The brain doesn't stop developing until the late 20s or early 30s. This may take even longer in men than in women. In some ways, the brain is never fully developed because it is constantly reshaping to meet the demands of everyday life, as well as being shaped in part by its current environment. There is a complex and continuing bidirectional interaction between brain development and environment that persists across the lifespan. During adolescent years, brain circuits become better functioning and efficient. This is rapid brain development. Drugs, alcohol, and head injuries may disrupt development. Nevertheless, the brain is surprisingly resilient. It cannot predict for any individual how environment or genetics will affect the brain. We do know, however, that good social relationships help improve growth and development. This image is the brain developing over time. The purple color represents areas of high connection, meaning high development, and red is low connection, low development. Just take a look and notice what happens in the images over time. The brain develops from back to front, and the brain is not completely developed until later in life. The final section of the brain to mature is the prefrontal cortex, which is responsible for higher order functions of the cognition, such as complex problem solving and moral reasoning. Linking of different brain areas, such as the limbic system and prefrontal cortex, discussed above, also improves during these years. And this results in better brain functioning. Researchers suggest that a mismatch of maturation timing between the limbic system, maturation often in early adolescence, and the still developing prefrontal cortex is what makes adolescents more prone to risk-taking behaviors, but also promotes creativity and more flexible adaptation to their environment. The teen brain is different from the adult brain. Gray matter starts in the back of the brain and in the motor cortex and then moves forward. The last aspects to develop are the higher cognitions, such as morality and problem solving. The function of the brain can be described with 6 primary domains. Thinking or cognition, this is problem solving, memory and computation, perception or sensing, hearing, seeing, tasting, smelling, emotion or feeling, this is mood regulation, signaling, alerting itself to danger, physical or somatic, heart rate regulation, breathing, body functions, etc., behavior, interaction with the environment. We can use the brain functions to classify the mental disorders. This classification isn't perfect, but it can act as a framework for teaching them. When perturbations arise in the different cell circuits that underlie each of the brain functions, this may lead to a mental disorder. How can I tell if it may be a mental disorder? Good understanding about mental health disorders and range from normal and negative states. Critical consideration of the weight of evidence. Self-awareness, knowing that you're not alone, enlist the assistance of others, and differentiate between crisis, urgent, and non-urgent. You may need to engage in watchful waiting. Mental disorders are also called mental illness or psychiatric illnesses and are categorized according to diagnostic criteria. There are 2 different sets of diagnostic criteria: the International Classification of Diseases, ICD, Diagnostic Statistical Manual of Mental Disorders, DSM. Both sets of criteria are similar in that they consist of syndromes, collections of signs and symptoms. Individuals may be outside the norm in 1 or more domains of brain functioning, but unless the signs and symptoms they experience fit into a syndrome, they don't have a mental disorder or mental illness. They may, however, have mental distress that can be helped by psychological activities such as counseling and social supports in the community. Not all disturbances of brain functioning are mental disorders. Some can be normal or expected responses to environment. For example, grief when somebody dies, or acute worry, sleep problems, and emotional tension when faced with a natural disaster such as a hurricane. The period of time before symptoms and impairment meet is considered the prodrome. Typically, we see symptoms before we start to see impairment. Example, we see the inattention of ADHD before the impairment affects academics at school. Just like arrhythmia and chest pains may be the prodromal phase of heart disease. Sometimes there can be symptoms that never progress to a full-blown disorder. Questions to consider when determining whether or not the student is likely to have a mental disorder. The quick screen method. Is the student's emotional state, cognitive function, or behavior very distressing or cause significant problems to them or to those around them? Does the student exhibit a lack of social convention that he or she is unaware of? Are the student's emotions, reasoning, or behavior markedly different than his or her social, cultural, or economic peers? Are those people who are closest to and most caring of the student seriously concerned that the student may be ill, even if they attribute the problems to be an environmental condition? These are all skills that we learn at school. Reading comprehension, judgment insight, contemplating, focusing, planning, etc. Disturbance in thought content. When we have disturbance in thought, we may have a delusional belief. Delusions are fixed, unbending beliefs that are incompatible with the beliefs held by the majority of people in the individual's cultural or subculture. What are delusional beliefs? Again, they are fixed, unbending beliefs that are incompatible with the beliefs held by the majority of people in the individual's culture or subculture. These beliefs are held with rigid conviction despite incontrovertible or obvious evidence of their falsehood. False, not real. Persistent, they don't go away. Not shared by others of the same socio-cultural group. Family and friends find it odd. Regarded as real and held with conviction despite being given ample evidence to the contrary, no proof is enough. Must be evaluated from within social cultural context, not in line with cultural beliefs. Some examples and types of delusions. Some of the more common types of delusions are grandiose, persecutory, religious, jealous, and somatic delusions. Grandiose delusions are inflated worth, power, knowledge, identity, or a special relationship to a deity or famous person. Persecutory delusions, delusions that the person may be malevolently treated in some way. Religious, individuals' belief revolve around religious themes. Example, belief that he or she has been selected by God to carry out his bidding. Jealous, delusions that the individual's sexual partner is being unfaithful. And somatic, delusions that the person has some physical defect or general medical condition. Perception. Here are the 5 senses. There are other senses, such as our ability to sense our body in space, or the overlap of 2 senses, the seeing of colors when you hear music. The disturbances of our perception. On the top line, a person looks and sees leaves, and there are leaves that are normal. In the middle line, a person looks at the leaves and sees faces. That's an illusion. On the bottom line, there's nothing there, and the person sees leaves. This is a hallucination. Hallucinations can be any sensory modality and arise spontaneously from within the brain without any external stimuli. Remember that illusions and hallucinations can occur in healthy brains at times, and these can be normal. Optical illusions are seeing a person who has died while grieving. Remember that illusions can at times happen in the healthy brain. Keep in mind, hallucinations are somewhat normal. It's common to think you hear someone call your name. Being unable to distinguish if things are real or not is a psychotic symptom. Mental disorders of cognition and perception, psychosis. Psychosis definition, a severe mental disorder in which thought and perceptions are so impaired that contact is lost with external reality. Schizophrenia. Schizophrenia is a mental illness which affects one person in every 100. Schizophrenia interferes with a person's mental functioning and behavior, and in the long term may cause changes to their personality. The first onset of schizophrenia is usually in adolescence or early adulthood. Some people may experience only one or more brief episodes of psychosis in their lives, and it may not develop into schizophrenia. For others, it may remain a recurrent or lifelong condition. The onset of the illness may be rapid, with acute symptoms developing over several weeks, or more commonly, it may be slow, developing over months or even years. During onset, the person often withdraws from others, gets depressed and anxious, and develops unusual fears or obsessions. It is characterized by two different sets of symptoms. Positive symptoms refer to symptoms that appear like delusions, thinking things that aren't true, or hallucinations, seeing or hearing things that aren't there. Negative symptoms refer to things that are taken away by the illness, so the person has less energy, less pleasure, and interest in normal life activities, spending less time with friends, being less able to think clearly. What are the symptoms of schizophrenia? Positive symptoms of schizophrenia include delusions, false beliefs of persecution, guilt or grandeur, or being under outside control. These beliefs will not change regardless of the evidence against them. People with schizophrenia may describe outside plots against them or think they have special powers or gifts. Sometimes they withdraw from people or hide to avoid imagined persecution. Hallucinations, most commonly involving hearing voices. Other less common experiences can include seeing, feeling, tasting, or smelling things which to the person are real but which are not actually there. Thought disorder, where the speech may be difficult to follow. For example, jumping from one subject to another with no logical connection. Thoughts and speech may be jumbled and disjointed. The person may think someone is interfering with their mind. Other symptoms of schizophrenia include loss of drive, when the ability to engage in everyday activities such as washing and cooking is lost. This lack of drive, initiative, or motivation is part of the illness and is not laziness. Blunted expression of emotion, where the ability to express emotion is greatly reduced and is often accompanied by a lack of response or an inappropriate response to external events such as happy or sad occasions. Social withdrawal. This may be caused by a number of factors, including the fear that someone is going to harm them, or a fear of interacting with others because of a loss of social skills. Lack of insight or awareness of other conditions. Because some experiences, such as delusions or hallucinations, are so real, it is common for people with schizophrenia to be unaware that they are ill. For this and other reasons, such as medication side effects, they may refuse to accept treatment, which could be essential for their well-being. Thinking difficulties. A person's concentration, memory, and ability to plan and organize may be affected, making it more difficult to reason, communicate, and complete daily tasks. Facts about schizophrenia. Schizophrenia is a chronic lifelong disorder, often requires lifelong treatment. Symptoms are disabling to the individual and distressing to family and friends. 1 in 10 people with schizophrenia commit suicide. The burden for caring for people with schizophrenia most often falls on families. Schizophrenia is not caused by poor parenting. Schizophrenia is not split personality. Schizophrenia runs in families. The exact cause is unknown, but it is a brain disorder. Schizophrenia is not caused by stress. Schizophrenia affects 1 and 2% of people worldwide. Men and women are equally affected. Medications can help reduce and control symptoms. Psychosis, what to look for. Schizophrenia is not related to multiple personality disorder, now called dissociative identity disorder. DID is very rare, and there is little evidence to suggest it even exists, no matter what Hollywood says. It would be more linked to trauma than schizophrenia if it is real. So other things to look for: is the person acting in a strange manner? Do they show signs or admit to hallucinations? Do they show a thought disorder? Does his or her speech make sense? Are they isolating? Are they espousing bizarre and unusual ideas? Is there a gradual decline in many areas of functioning? So what do you do? If a student is in a psychotic state, access urgent care through an emergency department. Do not be confrontational with the student, argue with their delusional beliefs, or say, I am concerned that you are experiencing this. We need to get you some help. If non-urgent, provide mental health assessors with needed information following appropriate consent provisions. Participate in discussions with the student, health providers, and family about school-related issues to modify school and academic activities, and clarify the role of school protocol for potential crisis situations. It is futile and agitating to try to talk to someone out of their delusional beliefs. So what do we know about treatment? Youth with schizophrenia can still be successful, especially with supports and interventions. Treatment does depend on genetic responsiveness. Medications still have some side effects, but they are getting better. Positive symptoms respond better to the current treatments available when compared to the negative symptoms. A person who is properly medicated may no longer have hallucinations or delusions, but still may suffer from flat affect and low motivation. Some additional concerns with psychosis. Voices telling the person to harm him or herself or others. Delusions that can lead to unpredictable behavior. People who have schizophrenia are not violent unless they are acutely ill. Emotions and mood. What am I feeling inside? One of your brain's key jobs is to regulate your emotional state. Most mood symptoms are normal. Positive and negative emotions are not signs of a mental illness. There is an intrinsic brain function that controls mood, and mood oscillates. In all of us, we have normal emotional changes. They happen naturally, all by itself through the interaction between our brain and environment. This is a normal mood chart. Everyone's mood changes over time, no matter what is going on in the environment. Your mood changes over the day, it changes over the month, it changes over a year. Your body works to maintain a set point through homeostasis. You have no doubt knows that some people are more like Tigger and some are more like Eeyore. Even so, we all have fluctuations and a set point of what is normal for us. When the homeostatic mechanism is broken, so the baseline, we have depression. Notice that there are still changes in mood, but the overall set point is lowered. We must always consider a student's baseline mood. What to look for in depression? We're looking for a shift from the student's baseline behavior. Remember that depression does not require an environmental trigger. So we will see frequent and persistent physical complaints, the loss of interest in usual activities, loss of pleasure in those things that they used to find pleasurable, decreased functioning at home, at work, and school, withdrawal, and poor concentration, hopelessness, thoughts of death, suicide, or preparation of death. What do we do? When the brain is depressed, it isn't just the mood of the individual that is impacted. When you are depressed across multiple domains, academic function is impaired. A student who is depressed in their social life, depressed in their math, depressed in their English. The body may be depressed and suffer from aches and pains. So some things that you can do is to modify academic expectations, implement mood-enhancing activities, be aware of the risk of suicide, and discuss with health providers what the role of the educator should be in each student's case. Collaborate with service providers with consent, develop a crisis plan, and always, if possible, get family engagement. What do we know about treatment for depression? For teens, treatment of the acute episode usually takes between 8 to 10 weeks before substantial improvement takes place. Treatment for depression takes time, even commonly 10 to 12 weeks. But even though a student feels better after 3 to 4 therapeutic sessions, they may need to continue treatment to prevent relapse. Adults tend to respond quicker, 4 to 6 weeks of treatment. Early identification and effective treatment are critical in treating depression. We don't want the brain to lay down patterns and pathways for chronic depression. Additional concerns. Always ask about suicidal thoughts and suicide plans and refer to a qualified professional for assistance. Substance abuse is often found with depression. Express empathy and concern and always ask about suicidal thoughts and suicide plans. If you are not sure an individual is depressed, ask someone with clinical expertise to evaluate immediately. Substance abuse. Remember that thoughts of death and suicide are signs the individual needs to get help. Only qualified professionals should conduct risk assessments. Rapid shifts between poles, bipolar disorder. If the regulatory system is broken, we may also see bipolar disorder. Typical periods of depression, the lower pole, and longer in duration than the manic periods. Bipolar disorder causes unusual shifts in mood, energy, activity levels, and the ability to carry out day-to-day tasks. The disorder involves clear changes in mood, energy, and activity levels. These moods range from periods of extremely up, elated, and energized behavior known as manic episodes, and very sad, down, or hopeless periods known as depressive episodes. Less severe manic periods are known as hypomanic episodes. Sometimes a mood episode includes symptoms of both manic and depressive symptoms. This is called an episode with mixed features. Because bipolar has a large genetic component, immediate family members of someone with bipolar are at much higher risk of having developed the disorder than people without bipolar in their family. Less than 2% of people have bipolar disorder of any type, and it is almost equally as prevalent among women and men. It usually begins in the late teens to early 20s. The symptoms of bipolar disorder can be subtle or extreme. Mild bipolar symptoms may sometimes be confused with being a teenager. Typical teenage strife does not cause bipolar disorder or any mental illness. The first episode is generally depression, occurring in adolescence. It can be clinically challenging to determine bipolar or depression. Mania is no sleep or very little sleep, a few hours. Mood is irritable. Pressure to speech, rapid speech, overactivity. Social disinhibitions, which is a safety issue. Drugs and alcohol may be used to cope and reduce mania. In a manic state, a youth may do potentially embarrassing things and may need more support in reintegrating back into school. What do we know about treatment? This is the most at-risk group for death by suicide because unlike unipolar depression, there are periods of energy increasing the risk to enact a suicide plan, creating a state of depression. So people with bipolar disorder usually require psychiatric care and ongoing monitoring, and sometimes hospitalization is needed. Medications are necessary for depression, and psychosocial treatments are also often needed. They may need academic modifications to accommodate for cognitive problems. And bipolar, as I said, substantially increases the risk of suicide. That concludes part 2. Please go on to part 3 of 5.